All right, so this is Chapter 3, Recording 1 for Medical, Legal, and Ethical Issues. We go back to our national standard competencies. Everything in this section is going to be preparatory. Medical, legal, and ethics, everything that has to pertain to that is something that you must be taught. So, one thing that you kind of probably have heard or learned throughout the years is the concept of first do no harm. That's mainly going to be for physicians, but that is still something that we strive to do. Somebody's already hurt, somebody's already struggling, somebody's already sick. The best thing that we can do for them is to not cause any further harm. Oftentimes we will be caught up in lawsuits, be it something that we did, something we didn't do, the patient suing somebody else, and we get pulled into it. The best way to protect yourself is to act in good faith. Do everything that you think is necessary for the patient and follow your appropriate standards of care. The other thing that you can do to save yourself is document, document, document. Make sure that you are thorough. Make sure that you put in detail. In the new age of checkboxes and not a lot of typing, that art of writing a really good trip report is starting to get lost. But truthfully, the more details that you put, the better that you can protect yourself. Oftentimes, we're the first ones on the scene. We may have fire in a dual response system such as Sioux Falls, where the engine responds to medical and trauma calls to help us out. It may be that we beat police officers to what we don't even know is a crime scene, but often we're the first ones on the scene. We get a look at everything before it's been tromped through and moved, and we tend to do a lot of that moving ourselves. There's no point in doing CPR on the person that fell between the bed and the wall. Either pull the person out or scooch the bed over. But oftentimes those people that are going to be doing any sort of litigation for these calls are going to arrive well after we've been there, possibly even after we leave. One of the biggest things that you need to work on and need to understand is getting proper consent before and even during patient treatment. So when somebody gives you consent, they say, yes, you can take care of me. It sounds silly, but any person that is of sound mind and legal emancipation, typically going to be somebody 18 or older, so adult age, has the right to refuse treatment, even if it could result in their death, ultimately. But they're allowed to choose. They have autonomy over themselves. Parents have autonomy over their children, and the situation that's going to get more frustrated is going to be when you want to provide appropriate treatment for somebody and either themselves or their guardian says no. If the patient or their guardian is conscious and of sound mind, they're making rational, or have the ability to make rational decisions, they have the legal right to refuse care. The foundation, the thing that their ability to make decisions for themselves, what it rests on is capacity. Do they understand the information that you've given them? And can they make a good informed choice regarding that specific medical care? While the person has the autonomy to make that decision, you can still talk to them. It's not necessarily a scare tactic to say, hey, if I don't do this for you, if you don't go to the hospital, if you don't get checked out, there is a possibility that you can die or have one of these other side effects, lasting effects. You need to inform them what their refusal of care could potentially lead to so that they can make an informed decision. Expressed consent. So this is where a patient actually says, yes, I want you to take care of me. Please take me to the hospital. In order for expressed consent, which is literal, like, yes, please take care of me, I understand, you have to provide informed consent. So explain your treatment, risks, benefits to patients. Oftentimes we don't go as in depth truly as we should, just because we're in chaotic scenes. We have limited exposure to our patient before we have to take life-saving measures often. But if you say, hey, I need to put an IV in your arm, and they stick their arm out, or hey, I need to take a blood pressure on you, and they stick their arm out, that is express consent. They are willingly giving you that appendage so that you can provide medical treatment or assessment on them. Some of the things that may affect a patient's ability to give consent is their intellectual capacity. They might be impaired by mental limitations, dementia. They may have developmental disabilities that could make it so they can't give consent. Do they still hold their arm out when you ask them to take a blood pressure? Quite possibly. But does that mean that they are fully giving consent? Something to keep in the back of your mind. Is the patient impaired by alcohol, drugs, serious injury, or illness that could impair their ability to make a sound judgment? Again, sometimes when people are intoxicated, we have to do things against their wishes, because if they were not intoxicated, it's possible that they would choose to have the proper care for themselves. If they're experiencing significant pain can definitely be a huge distractor. And somebody may just say, just give me pain meds. I don't want to deal with this. And they're not thinking clearly because they're so obtunded by the pain. Hearing visual problems can be a huge thing as well. If they can't receive the information, it's hard for them to give expressed or implied consent. And a lot of times you may not know that this is going on. I know my grandmother can't hear a darn thing, but if you talk to her, she will continue to acknowledge you, because she's found over years of saying, what? Or can you say that again? That people get frustrated with her. So rather than just go with the embarrassment of, yeah, I definitely can't hear you, she just nods and smiles and has no idea what we've said. So she may look like she's giving express consent, but has no idea what the heck you're doing. On top of express consent, we have another type of consent. It's called implied. So patients that are unconscious, are incapable of making a good decision about their care for one reason or another, can fall under implied consent. So it really applies when a serious medical condition exists, either medical or trauma, and it shouldn't be used unless there's threat to life or limb. However, if a person is unconscious, can we truly assess them well enough to know that there isn't a problem? We can't. So they fall under implied. Those that are severely intoxicated often can fall under implied consent as well, because they are under a mind-altering substance that, if they were in their correct mind, would be able to make a true informed decision. Sometimes what may indicate a serious threat is pretty unclear, and you may fall into litigation if you continue to take care of that person. If you truly believe they are incapable of making a proper decision, not just that you don't agree with them, but that you don't think that they fully understand, and you choose to get them treatment against their will, you need to document why you came to that conclusion. Oftentimes, you need to get others involved, police officers, etc., get them involved in care so that you aren't the only one holding liability. If somebody is drunk and fighting, has an obvious injury, and does not want to go, oftentimes, you can say, hey, either you can ride in the back of the ambulance with me to the hospital, or my friend over here with the handcuffs will take you and give you a ride. Your choice. So often, we can play that card. We want to be very cognizant of when we play the riding with the cops versus riding in the ambulance card, because you're going to eventually come across somebody that's like, all right, fine, I'll go with them. And if they have no legal grounds to take them, it could get a little sticky, but just that card is there should you need to play it. If you have somebody that has a family member, a guardian, next of kin with them, and you need to use implied consent, it's always a good idea to ask that other person, is it okay? Because then you're bringing somebody that truthfully knows that person into it, and they can say, yeah, if he wasn't drunk, if he wasn't unconscious, he wasn't whatever, he would go to the hospital for this. So that kind of takes some of the heat off of us as providers. Involuntary consent applies to patients who are mentally ill, in a behavioral or psychological crisis, are developmentally delayed to the point where they don't understand what's happening. If you can, you need to obtain consent from a legal guardian or conservator. There may not always be instances where you can do that, but this is a situation where you may have to get the police involved, especially with the mentally ill or psychological crisis, in order to protect yourself, just to make sure that they're okay. It doesn't even matter if they seem calm, you can be at significant risk. Minors in consent. This is when a parent or legal guardian needs to give some consent for you to treat a minor. So typically anybody under the age of 18. However, there are some instances where somebody under the 18 threshold can give consent for themselves. It depends a lot on states who have said, yes, we understand that they are under the legal age of adulthood. However, age maturity, they can make some decisions for themselves. Emancipated minors, if they're married, in the armed services, or if they have children of their own, they can be legally emancipated without having to go through the emancipation process. But they do need to provide you with papers or some sort of proof. You can't just take their word for it. Keep in mind that teachers, school officials can act in place of the parents. It's called in loco parentis. They can provide consent for treating of injuries if they're at a school function, a school sport, a camp setting. That's one of the papers that you have to sign for your child to participate in any sort of school sport, is the consent for treatment form. They should have that on hand. If a true emergency exists and no consent is available, treat the patient. It's implied just as it is with an adult, because they can't legally give consent. You need to do what's right for that patient. Never, ever withhold life-saving care for a minor because their guardian or parent is not there to say, yes, do it. That is another form of implied consent. We've had instances where, though, we've had to take in 16, 17-year-olds, minor fender bender, somebody called 911, we actually can't release them unless it's to a parent. So sometimes you do end up transporting somebody that may not necessarily need it just on those grounds if you can't get a hold of a parent. At least in the states that I've worked in, It doesn't matter. If they're under the age of 18 and not emancipated, they cannot give legal consent for themselves. So just things to keep in mind. Forcible restraint. Do we ever have to restrain a patient against their will? Absolutely. Absolutely. It's necessary with patients that need medical treatment and transport, but are combative and they present a significant risk to themselves, to those around them. It's necessary. Is it legally permissible? There's a couple of things that you need to do in order for it to be. Generally, we try and consult medical control for authorization. There are certain instances that are set within protocols that say, hey, if this is happening, restrain them. In some states, only law enforcement officers can forcibly restrain. So we don't use handcuffs. We don't use leather straps. We have soft, quick release restraints that are acceptable in most instances. And it's not necessarily even if they're combative. But to protect you, to protect them, it may be necessary. Conscious, alert adults with decision-making capability have the right to refuse treatment. They, irregardless of what the outcome is, it could result imminently in their death or serious injury, and they still can say, no, I don't want it. It definitely puts a lot of pressure on us to make sure they know what they're saying. They know what their decision is, what treatment is required, and it can be very frustrating for us. Make sure before you leave a scene, you want to continue to encourage them to allow care. If I have a patient that I know needs treated and they have a family member on scene, I will explain things to them in front of the family member, especially if it's like a husband that doesn't want to go in and the wife is sitting right there. I make sure that I impress upon them both the seriousness of the situation, because oftentimes that family member is going to get them to go when you're not going to be able to talk them into it. So another angle to work it. If they still say, no, I'm not going, ask them to sign a refusal of care form. You have to have witnesses sign this as well. You need to document that you discussed with them, what's going on with them, the needed treatment, what happens if they don't get the treatment. And then one thing that we always say is, if you get worse or you change your mind, you can always call 911 again and we'll come back and take care of you. You have to let them know that even though they're refusing care at this second, even if you walk out the door and they change their mind, you are always able to come back and help them out again. We'll go ahead and take a break here and we'll continue in recording 2.